Hello, Larry Parsons here. Welcome back to Passion for Palliative. As we said in our introduction, this is a channel we're going to put content on that focuses on the broad spectrum of hospice and palliative medicine, with the hope would help people, nurses, doctors, providers, etc., to have some very quick resources for topics in this important specialty. I've been told by my lawyer daughter that we should, give some kind of disclaimer for everything. This is just our opinion, and to see if it could be helpful to you all. One of the things I like to recommend to my friends or people that are interested in palliative medicine as a resource is this book right here, Hospice and Palliative Medicine Handbook. And it says a clinical guide. And the authors here on the back, they're Susan Botke and Kathy Ligon. Both of them were trained at the San Diego Hospice and worked there. This is really, of all the books that I have, is a really nice and handy one to have. The focus is more of a West Coast approach to palliative medicine, and you'll see medicine is very regional, but I found it as a very helpful resource for those that do this type of work or are interested in it. The topic today, April 29th, 2020, will be our first topic. And it's something I think is really, really important. It's differential diagnosis of agitation in hospice and palliative patients. So I want to start with topics that I see the biggest, most common errors in folks, even if you're a hospice nurse or a hospice physician, oftentimes err in this particular symptom management issue in patients with life-limiting illness. There's essentially, and I want to make this as brief as possible, as I don't want to belabor things, there's essentially three major possible causes of agitation in particularly hospice patients, people at the end of life. Often the agitation tends to be a delirium, a picture where they aren't able to explain very well what is going on. And so oftentimes I have nurses call me and they think that this agitation, and I have them explain to me, what do you mean by agitation? What's the patient doing? What's the presentation? So often the first in the differential, of course, would be pain or shortness of breath. Certainly that's something that we often consider. And in fact, in my experience, almost universally, the first thing and the only thing that people think of when people on hospice are agitated is that it's related somehow to these problems, okay? And obviously you have measures to treat these. Often, again, we're going to use an opiate to treat these symptoms, okay? As a hospice physician, often you're not actually seeing the patient, so what's really important is to have good rapport with your nurses or your providers and really ask them to help you understand, build a picture for what this patient looks like, okay? It's also very important in any differential diagnosis to know what the diagnoses are for this patient, what medications they are on, any new medications or changes in the medication, dosages, what's their level of alertness, what's their PPS, etc. So you want to know something about the patient in order to really get an idea of what your differential is going to be. Second, and here's what I think is the most important and is most often overlooked, and that's the second of the three that are the big three, and that is delirium or metabolic encephalopathy. Oftentimes, actually, agitation is from from this particular issue. Just a clinical case, for instance. I had a nurse call me, a hospice nurse at a hospice house, call me on a patient who was quite agitated, and the nurse wished to increase the dosage and of morphine on this patient. Felt it was secondary to pain because there was grimacing, there was agitation, but the patient on questioning wasn't really able to express what their symptoms were. But again, this was a person who had so furrowing of the brow, movement of the extremities, etc. I asked the appropriate questions about what this patient medications, etc. And what I had found is that this patient had had a rapid escalation of the morphine for presumed pain. Okay, and to the nurse, the patient seemed to become more agitated. So the thinking process was, oh, this patient's pain isn't being managed well. Whenever I have a situation like that, I always ask the nurse, why does this patient hurt? What hurts on this patient? In this particular patient, the patient had had a non-hemorrhagic stroke, and one has to think about, well, do strokes hurt? Are they painful? And in general, they're not painful. So I really try to explore, I think it's important to explore, what is the etiology of this person's pain or shortness of breath. Once you get a good answer to that, and you look at what medications the patient has been taking, then you say, okay, what level of opiate would I expect to address those symptoms? One of the examples I use is fractures. Most people have had fractures of long bones or even their spine, and I ask the nurse or whoever my audience is, how many have had a broken bone, and how much Lortab, which is often used for pain, how many pills did you have to use? And typically the answer is at the most 3 or 4 Lortab a day, or at the most 20 milligrams of hydrocodone, which is equianalgesic with 20 milligrams of oral morphine. And frequently in these patients, again, I see this situation over and over again, the patients have had 50, and one time I saw 120 oral morphine equivalents in 24 hours. And you can draw the conclusion they probably have enough medicine on board to take care of that pain. So that's the kind of approach that I'll take to helping with this differential. And again, once you think it's likely delirium, then use whatever your medicine you like to use for delirium. Appropriately, of course, I use Haldol a lot, or depending if you have someone with Parkinsonian syndrome, a Seroquel, or quetiapine, haloperidol quetiapine, or whatever. You choose your medication. And then I typically will have the nurse call me back in 2 hours to tell me how that went. Now, obviously, if the person can't swallow, you're going to use something parenterally, sub-Q, for instance, or you can use if you're using olanzapine, an ODT will often work. But I have them call me back in an hour to an hour and a half, 2 hours. How did that affect the patient's symptoms? And oftentimes I'll get that call back within an hour and a half with a very surprised nurse and says, wow, the person's very, very comfortable. The other thing, again, to think about, when you escalate opiates, and oftentimes I see that, you really have to think, particularly morphine, which is most anticholinergic of the opiates, does this person have urinary retention? And oftentimes, if you don't have a bladder scanner, I'll just say, why don't we go ahead and put a Foley in and see what we get. And frequently we'll get 600 milliliters of urine, that type of thing. So those are the issues. You've got to think about what dose you're giving, what your possible side effects are, what's your expectation of response to the amount of opiate you're giving, etc. You also have to consider under what setting are we in as far as the patient's concerned. So oftentimes, honestly, the delirium is often not thought of, I think, as frequency as it ought to in the differential diagnosis. The key is you have to have a differential diagnosis, and the approach I take is, you know what, I could be wrong. Whatever I'm thinking, it's easy to get tunnel vision in medicine, and you have to have that humility to say, I could be wrong, and really talk to that person on the ground and really get a good information from them. The third is spiritual distress. Spiritual distress. Oftentimes we don't think about this. I remember I had a patient who, again, I felt the nurses were barking up the wrong tree as far as the pain shortness of breath was concerned. I had a lot of opiate on board. I started giving this gentleman haloperidol, and I gave him good doses of haloperidol. I'm not afraid to use a lot of haloperidol at the end of life. And this guy just wasn't getting comfortable. So I actually went in to see this patient. I said, I'm not, and it hit me as I was driving to the hospice house. I said, okay, Larry, what's your differential diagnosis? And I said, you know what, spiritual distress. So family members were in there, and I went in and I said, is this guy a veteran by any chance? Oh, yes, he was a Marine, and this guy had been in a lot of conflict, a lot of battles, once we were able to get, I believe it was a priest at that time, this person was Catholic, and kind of working with the family, when this actually patient woke up, we were able to work through some things. This guy relaxed and had a much more comfortable death than if we had not considered this. And so I think this is another one that we don't think about enough: spiritual distress, existential distress. So we have to consider that. One of the other approaches I use as a hospice physician, I think it's really wise for you physicians to really listen closely to this, is or providers. I often ask the nurse after we walk through what my thinking is as far as the differential and what I think. I ask, are you comfortable with the plan? Oftentimes I'll ask them, give me a plan, and then we go through it. But if I give a plan, are you comfortable with that plan? Oftentimes what I find, if someone says no, you better listen to that. Something's going on. And I really try to explore, tell me about that. Because oftentimes that, and I think in palliative medicine, if you're in one, there's a gut feeling there too that you have to listen to and say, I'm uncomfortable, there's something else going on. And that's when you ask more questions and listen more closely. So again, I want to keep this as brief as possible. Whenever you have an agitated patient, when you're called, what is the agitation? What does it look like? Tell me what the patient's doing. Can the patient talk, etc. Go through that. What medications are they on? What are their illnesses? Any recent changes in medications? Again, just go through the whole story. What's their social situation? What's their spiritual situation? And then think through the data that you have. What medications should the medication, usually an opiate, would that have covered, would I have expected that to cover these type of symptoms? Does the person have a good reason to have delirium or not? Now remember, at the end of life, 85% of people get terminal delirium, so this is pretty common, okay? And then also, don't neglect the psychosocial, existential, spiritual aspect of your patient. Again, thanks. We'll continue to cover topics we think are important, and please leave comments and questions, and we'll try to answer them. Thank you.